In today's episode, we're going to learn how historically black colleges and universities, also known as HBCUs, have been at the forefront of building a healthcare workforce that reflects and serves the communities they're a part of. Welcome to the Intersection Podcast. The Intersection is a project of the Robert Wood Johnson Foundation, built for advocates to share how they're partnering to create anti-racist health systems. I'm your host, Anton Gunn. Today, I'm here with Dr. Lisa Barkley from Charles R. Drew University, Dr. Leonardo Seoane from Xavier Ochsner College School of Medicine, Dr. Tabia Henry Akintobi from the Morehouse School of Medicine, and Dr. Marjorie C. Gondré-Lewis from Howard University School of Medicine. We're going to discuss how patient-centered care, culturally relevant education, and engaging the community can strengthen health equity and help build an anti-racist health system. Let's kick things off. Welcome, everyone. So happy to be here to have this conversation with you. We could start by introducing yourself, your name, your title, and your role. I'm going to start with you, Dr. Akintobi. Please share who you are.
Hi, thank you, Anton. I'm Tabia Henry, and I'm professor and chair of the Department of Community Health and Preventive Medicine, and I'm also Associate Dean for Community Engagement.
Fantastic. Lisa?
Hi, Lisa Barkley. I'm a professor of family medicine and chair of the Department of Family Medicine at Charles Drew University, and I'm also the Associate Dean for Community Benefit in our new medical school.
Fantastic. Marjorie?
Hello, everybody. My name is Marjorie Gondré-Lewis. I'm professor of neuroscience in our Department of Anatomy and Associate Dean for Faculty Development and Justice, Equity, Diversity, and Inclusion. And I lead our clinical translational science efforts at Howard University College of Medicine.
And Leo?
I'm Dr. Leonardo Seoane, and I get the privilege to serve as the founding dean of the Xavier Ochsner College of Medicine.
Fantastic. So great to be with all of you. So my first question for you is, what role do HBCUs play in improving health equity and building anti-racist health systems? So I'm going to start with you, Lisa, to give some context of what role HBCUs play.
Well, we play a foundational role in that because all of our missions have been founded because of that desire to promote health equity. So I feel that our medical schools are rooted in community. They actually research topics related to social determinants of health and health disparities and other topics that are important to the communities that we serve. We provide care to under-resourced communities that are traditionally left behind. We provide community service that's partnered with communities, not just thrust on them. I feel that all of our institutions have allied health professional training opportunities in addition to medical education opportunities. So we're really a place where health equity is demonstrated.
Fantastic. Marjorie, you want to add on to that?
Just our role in producing a lot of Black and brown doctors that go out into the community. They're more likely to serve the community than everybody else, and they go out not just to serve the people, but into spaces, professional spaces where they influence policy, culture, direction of different types of institutions. So we as a collective play a huge role in that.
Yes. So Leo, I want to have you to add on to that, knowing that you're from a newly developed partnership between a health system and HBCU in delivering training and education in medicine. Can you talk about what role you believe that you're playing now as a part of that process?
HBCUs, as Marjorie said, it trains minority physicians to be in spaces. And I love what she says that. And some of those spaces are practicing medicine in large health systems. As we know, independent practice physicians, about 10 years ago now, we have more employed physicians than we have independent practice physicians. Both spaces are important to delivering care, but having HBCU graduates from colleges of medicine in health systems and leadership roles in health system are spaces where decisions get made and therefore can influence the way we practice medicine and the way we co-create with our communities.
Fantastic. Now, Tabia, I want to ask this question particularly to you. Because one of the things we do as a part of this conversation is to try to help people to learn how they can be better. So, what can advocates, health systems, and others learn from HBCUs about serving and engaging communities, especially historically excluded and underserved communities? Can you give us some of your perspective on what people can learn from HBCUs?
Yeah, I think what we bring is the courage to understand that relationships and benefits by default should represent multi-directional value. I think our roles as HBCUs and what other organizations can learn from us is that the community residents, community-based organizations, they're not fraught solely with needs, but they represent strengths without which we cannot be as effective in providing not just competent, but culturally humble care that is responsive to the strengths and the existing power that we need to leverage to be better institutions, to produce better clinicians that are poised not to just lead, but to also be led by the perspectives of patients. The values that we talk about in our missions, we uniquely practice those by positioning community leaders and patients as central to our success. I think the other part that we demonstrate is trustworthiness, which is a term that lots of folks are using right now. That is not just a concept. I think everyone wants to say they are trustworthy, but that practice requires courage. When you bring folks that are not clinicians, that are from the community to the table to be a part of the decision making, to be a part of the team, that means that you're opening yourself up to accountability towards hearing what may not be comfortable, what may not be perfect, so that opportunity and those decisions to bring them to the table requires that we actually act in response and change the way that we deliver care and the ways that we train our students. So we have the courage to be accountable and to course correct based on the feedback that we get from community leaders and patient groups that are not just helping us to engage more patients or to recruit more research subjects, but to have them be a part of the foundation, whether it's the research question or the type of clinical care that we provide. They are partners with leveraged power that make us better.
That's great. With that word trustworthy, when you said that, I saw it struck a nerve with everybody. So, Leo, can you give some context, just adding on to the importance of trust in what you do in partnership with the community and health outcomes?
Look, my 25 years of practice, I've seen an incredible erosion of trust for the physician. It used to be you put on the white coat and you got instant trust from your patients. That is just not the case. And then for the minority communities, there's a lot of reasons for minorities not to trust the health system through multiple examples. I always think of Francis Fry's trust triangle when I think about building trust. You have to have authenticity, you have to have empathy, and then you have to have the knowledge too. And you need all three to build that trust. I think HBCU is at the forefront of training physicians that can earn that trust from the community, because they're training in the communities that we would like for them to serve, is a key component to that.
Yeah, Marjorie, your thoughts?
I immediately heard that word and started thinking about AI, actually, and this introduction of this behemoth of a technology that is seemingly unregulated. And healthcare has been trying to do that, to try to regulate how we use AI, and the idea of ethics and trustworthiness is really important, because what does AI do? AI gets inputs, right? And then it learns from those inputs and then spits out information based on what it asks. So who's inputting that information from which it is learning? And so it's really important that our voices are reflected in not only the medicine, the science, but in the community perspectives that go into that AI, so that we don't perpetuate biases about people of color. it's important in terms of decision making at the bedside, how clinicians use AI. And so we need a huge education campaign, all of these interdisciplinary groups that we've been talking about in ways of approaching what the thing is spitting out and evaluating what it's spitting out, informed by our own lived experiences and our being like we're part of that community too, to change some of the narratives that have been integrated and caked in our society for so many years, right? I correct AI all the time about stuff with HBCUs. And just an example, I was doing something and then it referred to HBCUs as low resourced institutions. And so that's in there, right? So it doesn't matter how much money we get, whether Howard becomes an R1 institution or not, or whether we get lots of federal funding, that AI is perpetuating that negativity. And so likewise for data around Black and Brown people, we need to make sure that that perpetuation doesn't actually hurt someone. The data that trains the model is really critical. Like we have to have a voice and evaluate the output for sure.
Yeah, fantastic. I totally agree. See, get lots of head nods on that. I heard this statistic, and I'd love to have you expound on it, that 50 to 70% of Black physicians are educated and trained at an HBCU before they go into practice in a community. That is super powerful of a statistic. We all know that there's some challenges in terms of a physician shortage that exists in the United States, and that challenge is going to grow. So I'd love to learn a little bit, how are your institutions attacking that challenge? I'll start with you, Leo, because I know it's something top of mind for you all in the institution.
Look, I think the physician shortage is a crisis. And whenever one of our family or our loved ones or a friend needs a rheumatology appointment and it's 9 months down the road, then it becomes real. But then it feels abstract. But it's real, and it's real today, and it's not evenly spread throughout the United States. Minority communities, rural communities, communities from the Gulf South feel that impact disproportionately. And we also know that concordance of care there's a growing body of evidence that when you have concordant care by ethnicity and race, you get better care. And so the burden has been borne by HBCUs. It will continue to be borne by HBCUs. I think all of us on this podcast have accepted that responsibility, but it is a true crisis that we need to work to. And I'll just speak to my state, the state of Louisiana, is that 33% of the population identifies themselves as Black, but only 11% of the physicians identify themselves as Black. And that is worse than the national data, where 14% of the population is Black, but only 5.7% of the physicians are Black. For Hispanics like myself, we make up 20% of the US population, but only make up 7% of the physicians. This is a crisis. Thank God for HBCUs, because you can imagine what the discordance would be without HBCUs. It's something that all of us should have top of mind.
Very good. Lisa, how about you add on to that?
I love what you're saying about the critical nature of this problem. To create a physician, it takes decades of training. So we really have to go back to our K-12 systems and really look at how our students are faring in their early education and provide them with access to providers who look like them and let them know that they can be physicians, because if they never see anybody who's doing it and they don't ever get encouraged to do it, they won't. So we have to approach this from multiple lenses, from the medical school angle, but also all the way back into the beginning of the pathway to those careers.
Fantastic. Tabia, can you talk about some of the challenges that HBCUs and HBCU medical schools face in doing the work that you do? We know that there's some structural challenges, some policy challenges, but give some perspective around the challenges that you face, and then what would you like to see different?
So I think that among our challenges is that a large proportion of the students that we accept are qualified with respect to their passion. And we know by the time they finish with us and are going into the residency program that they are students that are in fact aligned with our mission to lead the creation and advancement of health equity. But many of them are, we call them academically diverse. And so what we do know is that certainly their MCAT scores are not indicative of their ability to pass their board exams and go on to be physicians that not only know enough, but also have the values to become physicians that advance health equity and justice. But the other piece is that they frequently are coming from families where they are the first, whether it's first to go to college or first to be in medical school. And with that comes not just with the academic reality of being number one, but also with the financial burden that in part is met with the fact that our schools are private and med school is just expensive. And so they're qualified, they get in the door, but they have a lot of familial burdens that they welcome and are a part of their reality that, if not managed well with a village of support, can be overwhelming as they seek to navigate successfully through medical school. And so those challenges require faculty that certainly are excellent in their disciplines, but also have the humility and cultural understanding that our role is to also help these students navigate life, right? As uniquely qualified, uniquely excellent, but that have challenges and a lot in their backpacks beyond books that require us to teach different and to create opportunities for them to see light and opportunity along the way. So I think the way I would respond to the last part of your question, what would I like to see? I think all of us have to be prepared, and we've been doing this over the last few years more than ever before, to be advocates in using our voices to be among the first places that policymakers go to understand the impact on community health if issues surrounding caps on federal loans, as well as which professions are considered professions. They should be coming to us first and understanding the implications for the health of their jurisdictions and in the states where our medical schools are. This is not just about graduating uniquely qualified students, but it is about the health of the communities that they serve and want to ensure are well. So our voices in policy are absolutely essential. Many of us have learned the importance of it later, but when we have used our voices and empowered our students to also use their voices, I think it can make a difference. And our students' voices usually are more important. In many instances, we may have the statistics to share about those things that some of my colleagues mentioned, but their eyes light up and the community's eyes light up. And some of those community folks are those in local policy who want to hear and see a student that represents that lived experience.
I just wanted to add to that because retention is really important. I think the two questions that you asked both Leo and Tabia are linked to one another in an inextricable way because, yes, there are things that HBCUs can do or historically Black medical schools can do in terms of the shortage. Increasing class size, reducing the time it takes to finish medical school. That's something that we're actively discussing. You know, can they have the option to finish in 3 instead of 4 years? Because then that would reduce the loan amount later on. That would increase the number of people who can actually go and practice. And then Tabia talked about the practical aspects that we offer. That's where HBCUs differ because we do have retention programs to make sure that people aren't thrown out in the street with this shocker of a medical school program. That's a whole different animal for them. The opportunity to remediate. We spend money on tutoring. Certainly Howard does. We try to provide free study tools. The Robert Wood Johnson Foundation, with the grant that they awarded us, we're able to do things like provide food insecurity relief for individuals, or rent. A student who's studying for the boards, who's not yet matriculated, is in a position where they're worried about where they're going to live and how they're going to eat. and just other opportunities to make them great at what they do, right? To provide them the opportunity to go and present their work to the national space so that they can become the renowned expert early on and build on their CVs so that they can have access to different spaces. Just how do we respond to the shortage, the need for more students? And the other thing that Howard is doing is with the cap that we talked about of loan limits, we are using donations to provide scholarships that can maybe take care of half the tuition. Remember, our students take loans to go to undergrad. They take loans to perhaps do an in-between program in order to qualify for medical school, and then they have to take loans for medical school, and they're going to cap out very quickly. And so we need to find creative funding opportunities so that the students can concentrate on studying and moving their careers forward and not on eating, on whether or not they can afford tuition, etc.
Yeah, I really want to highlight that whole piece about the resources. So you asked about what would we wish that we could have better. I think we really need scholarships, things that they don't have to pay back. And trying to be creative, since so many of our students want to serve communities, trying to enhance those programs that exchange education for service in communities. I know that some of those programs are hard to maintain, but I think we should really look at the innovative ways that we can strengthen those kind of pathways for our students.
Yep. Well, I want to shift a little bit, and I'm going to ask this question because it's really important to me. I bet if I asked you when you were in the third grade and your teacher asked you what you want to be when you grow up, none of you would have said you wanted to lead an HBCU medical school. Maybe, maybe not. So that leads me to the question. I want to hear your journey. I want to know what led you to the place that you are now doing this work.
If you would have asked me in third grade, I wouldn't have been even said I wanted to be a doctor. I wouldn't have thought I could have been a doctor, to be honest with you. My dad was a garbage man, and my mom stayed home and raised 6 boys, and we were just trying to get by. But I think my career shifted to medical education when I was a physician, and I was always an educator. I was a teaching assistant in undergrad as a work study program, and I won the teaching award as an intern. I won the teaching award as a resident. I won the teaching award as a fellow. I won the teaching award as a young faculty. And so I realized that this is in my blood, in my DNA. It's what I enjoy to do, and I've always enjoyed being a clinical educator and a medical educator. And I grew up in New Orleans, and New Orleans is a majority minority city, and you see the need. And I already quoted the data for our state of Louisiana. And I also, let me add that 60 out of our 64 parishes in Louisiana are underserved by HRSA definition for physicians per population. Yeah. And so this ability to take an incredible organization like Xavier, that's 100-year legacy, and partner with the health system to develop a college of medicine to train physicians, diverse physician leaders, to promote a more just and humane society is a pinch me dream come true. The Gulf South is a special place. We're a special community, right? We're resilient. We're tough. We survived more than one hurricane. We've survived poverty. We've survived, structural racism. We've survived incredible amount of things. The city of New Orleans and the Gulf South deserves a college of medicine like Xavier. And so that's my purpose. That's my passion.
Very good. Thank you. Lisa, what was the third grade Lisa wanting to do, and then how'd you end up where you are?
Well, the third grade, Lisa knew I wanted to do something in science and I wanted to help people. By sixth grade, I knew I wanted to be a physician.
Oh, wow.
I was the first in my family to do so, so I had to really seek out mentorship and how to do it along the way. When I went to medical school, I knew I wanted to work with young people. I fulfilled that by specializing in adolescent and sports medicine. I ended up staying in academia because that was the best place that I could serve teenagers, because in academic medicine, you have opportunities to do research and do community work and other things that are harder to do in private practice. So I stayed in academic medicine and just kind of love that. I think staying in areas of my passion has led me to work at, this is my second HBCU. Charles Drew is a historically Black graduate institution and Hispanic serving health institution. And I've been led to these environments as an educational leadership because I feel passionate about the mission and aligns with my mission. And I feel that these institutions and being able to train the next generation helps to amplify what I can do as a physician. I got to the point where I could only see a certain number of patients per week. But if I worked at the level of academic leadership and training others, that really amplified how many teenagers and others I could really impact on through the work of helping others achieve. And then that also led to my desire to really focus on pathways to careers and really help young people reach their full potential.
Phenomenal. How about you, Tabia?
I was born in Canada to immigrant parents from Jamaica. I didn't know till maybe I was about 15 years old that we were officially classified as living under the federal poverty level. I didn't know what that meant. I was in a place, in a community where there was great social cohesion that my parents created in part from their values. And our floor and house, which I found out later on, it was not a house, was covered with a lot of family members that happened to be young people that had been kicked out of their homes, or they were students who were struggling just like my parents were. But the impetus and the focus on excellence and giving back was something that we did regularly, even though I found out later we didn't have much. So long story short, my passion and interest in community health and preventive medicine and public health was grounded in those lived experiences and the ways that my parents modeled being that support for learners and community residents along the way. And so through Morehouse School of Medicine, which was my first HBCU experience on faculty, really created the opportunity for me to ensure that my passion was met with an institution that was aligned with it. And that has allowed me to engage learners in research, but also residency programs that have allowed them to do the same thing. So it's very personal, and it comes from the otherness that makes me passionate about ensuring that students and communities are not left out.
Fantastic. Thank you. Marjorie, share your journey.
I'm so enjoying hearing these stories. It's taking me down memory lane and perhaps making me a little emotional here. So, shout out to my mom. She was a single mother who worked in a factory. She came here from Haiti on her own. She had 4 kids, which she managed to send back for. I used to come on vacation, but I came here to stay when I was in the 3rd grade. And so, this idea of you just had to do well in school because what are you doing otherwise? And so it was ingrained that you were supposed to do well in school. And of course, a lot of countries in the Caribbean and Africa, they have, that doctor, lawyer, engineer thing that you're supposed to be shooting for. My mom was like, you can be a nurse, it's okay, or you can be a social worker or something stand up-ish. She led by example and made me feel like I can do anything. So not having had more than an 8th grade education and working in a factory, she bought a house, she had stocks for Pete's sake, like not having mastered the English language. I don't even know how she did it. She had lawyers. I remember their names. It's like, who are you when we think about it? Because we all did well, and we came back and said, how did she do that? Because we're struggling to try to figure out this very complex system. So for an immigrant family, it was a pretty big deal. I wound up going to New York University for my undergrad and then Albert Einstein College of Medicine for graduate school. I remember in between, I was a research assistant, and I think that was key in helping me shape where I was going to go. At first, I just didn't want academia because the people looked very frustrated and they were coming in with a lot of pressure, especially for grants. And it was different than the 8 to 4 that my mom was doing. And then she came home and she was queen of the castle. Like her job didn't define her. And these people looked very, very frustrated. So it took me a long time to figure out that I wanted to do a PhD, looking at people, I was training them in the research methods. I was helping write papers as a research assistant and doing all that stuff. And I figured, okay, well, maybe I should just go and be a doctor too, And so I wound up there. I still didn't think I would be in academia, really. The path was anywhere. As long as I have a job and I'm functioning in that space, I would be okay. And then I came to Howard, and Howard gave meaning to a lot of what I was doing. It was no longer looking at specific mechanisms in the synapse. It became like, why is this important? How does that impact the community? And it changed the trajectory of how I think about my work. I may be using some of the same methodology to understand synaptic transmission, but it had to be important to the people. And so important to the students, important to the community, etc.
Awesome. Well, I want to thank you all for sharing the incredible history of HBCUs in shaping medicine, but more importantly, sharing your story for why you do this work and why it matters. A big thank you to our guests for sharing their insights and the amazing legacy of HBCUs in shaping a more diverse healthcare workforce. Thank you for being with us today. I'd also like to thank our listeners for tuning in. Don't forget to subscribe to the podcast to stay up to date with new episodes. We're available on Apple Podcasts, Spotify, YouTube, and Amazon Music. And as always, visit us at meetattheintersection.org for the latest events, conversations, and resources. The views expressed here do not necessarily reflect the views of the Robert Wood Johnson Foundation. The foundation does not support lobbying efforts, including any activities or communications referenced during this podcast.